Hi everyone, today we are going to discuss about the anti-anginal drugs. This man, while on exertion, he developed chest pain and the typical distribution of the pain was along the left side of the neck and radiating to the arm. This is known as angina pectoris. Angina pectoris, it is the ischemic condition which results from an imbalance between the myocardial oxygen demand and myocardial oxygen supply. So this is due to either decrease in the myocardial oxygen supply or increase in the myocardial oxygen demand or sometimes due to both of these conditions. Now coming to the types of angina. Stable or classical angina, which is a common form of angina, and this is usually provoked by physical exertion, cold weather, or emotional stimuli. You can see here in this figure that during the rest, the normal condition of the conducting vessels when during the exercise, the conducting vessels diameter increases to meet the blood flow and oxygen demand of the heart. During the stable angina, the flow cannot be increased because there is a fixed obstruction in the coronary vessels. So the flow will not increase. Another type is pre-mental or variant or vasospastic angina, which is an uncommon form. In this type of angina, there is a coronary vasospasm. So the flow decreases in case of variant angina. Unstable angina, it is caused by atheromatous plaque formation in the conducting vessels. This atheromatous plaque often ulcerates and it attracts platelet deposition which leads to the progressive occlusion of the coronary artery, and this usually occurs at rest, which may further precipitate to myocardial infarctions. Now coming to the anti-anginal drugs, these are the nitrates, beta blockers, calcium channel blockers. These three are the primary drug for the treatment of stable angina and variant angina. Other add-on therapy includes potassium channel opener, partial fatty acid oxidation pathway inhibitors, and sodium channel blockers. First, we will discuss about the nitrates. Nitrates are classified into short-acting or longer-acting nitrates. Short-acting nitrates include glyceryl trinitrate, isosorbide dinitrate, which when administered sublingually, they are used to terminate acute attack of angina. Longer-acting nitrates include isosorbide dinitrate in oral form, isosorbide mononitrate, erythritol tetranitrate, pentaerythritol tetranitrate. These are used in the chronic prophylaxis of angina. Now coming to the mechanism of action of nitrates. Nitrates will cause release of nitric oxide from the endothelium, and this will result in activation of the guanylyl cyclase. This increases the cyclic GMP, which causes dephosphorylation of the myosin light chain kinase. So, myosin acting interaction fails to occur and ultimately it brings about smooth muscle relaxation. So, this way nitrate relieves the pain in the stable angina. Now coming to the pharmacokinetic properties of nitrates. All the nitrates undergo extensive first-pass metabolism in the liver except isosorbide mononitrate. Now coming to the pharmacological actions of nitrates. Nitrates causes preload reduction, and that's how it causes venodilatation that will cause peripheral cooling of the blood, and that will ultimately causes decreased venous return. Preload reduction will cause decrease in the end diastolic intraventricular pressure, and this ultimately favors subendocardial perfusion during the attacks of angina. Apart from this, nitrate also causes afterload reduction, and This will result in subarterial dilatation and some decrease in the total peripheral resistance of the blood vessels. This ultimately results in decreased myocardial work. Apart from decreasing the preload and afterload, nitrates also causes favorable redistribution of the blood flow. So it dilates the larger epicardial coronary arteries in the ischemic areas of the myocardium. You can see here that there is a ischemic dilatation of the subendocardial resistance vessels. Nitrates, when they are given during the attacks of angina, it will cause dilatation of the larger epicardial arteries in the ischemic zone. So the flow will increase in the ischemic zone, while resistance vessel in the non-ischemic zone will maintain the tone. So this way nitrate will cause favorable redistribution of the blood flow, and that is helpful to relieve the attack of angina. Nitrates also causes dilatation of the larger coronary arteries, which is helpful during the attacks of variant angina, and the beneficial role of nitrates are by relieving the vasospasm during the attacks of variant angina. Now coming to the adverse effects of nitrates. Nitrates causes vasodilatation of facial vessels, so it can cause facial flushing. It can cause vasodilatation of the meningeal vessels, so it can cause headache, dizziness, fainting, which results in postural hypotension. This can be prevented by lying down posture. Because of postural hypotension, it will cause sympathetic stimulation. This will ultimately result in reflex tachycardia as a side effect. Methemoglobinemia and rashes are the side effect of pentaerythritol tetranitrate. Nitrates can also cause development of tolerance if they are continuously present in the body. Repeated administration of a given dose of organic nitrate will produce decreased effect on long-term use of the nitrate. This is particularly true for oral transdermal patch or IV infusion of nitrates. 8 hours of nitrate-free period every day is recommended to prevent the development of tolerance in long term. Now coming to the drug interactions, sildenafil, phosphodiesterase inhibitor, can cause vasodilatation, and so it can result in severe hypotension when it is administered along with the nitrates, and sometimes it may even result into myocardial infarction and death of the patient. Now coming to the role of nitrates in angina pectoris. These are useful in the treatment of classical and variant angina. Sublingual glyceryl trinitrate 0.5 mg, isosorbide dinitrate. These two drugs can be used to terminate the acute attacks of angina. Longer acting preparations like oral and transdermal nitrates can be used for chronic prophylaxis. Nitrates increases the exercise tolerance. Nitrates plus amlodipine combination is used for the treatment of variant angina as well as for the stable angina. Now another class is beta blockers. Metoprolol, atenolol, bisoprolol, all these cardioselective beta blockers you can use in the treatment of angina pectoris. So beta blockers antagonizes the actions of epinephrine and norepinephrine, which is released by sympathetic stimulation during the stress or exercise. This will ultimately decreases the arterial blood pressure, and beta blockers also decreases the heart rate, contractility and systolic wall tension. This will ultimately decreases cardiac work and oxygen demand. Now coming to the adverse effects of beta blockers. Non-selective beta blockers like propranolol, they can cause powerful bronchoconstriction in chronic airway disease patients, and it can precipitate acute attack of asthma. That's why propranolol is not used in the treatment of stable angina, especially if the patient is also having a history of asthma. Apart from this, beta blockers can also cause bradycardia, AV nodal block in the patients with the conduction disturbances. Abrupt withdrawal of the beta blockers can even worsen the angina on long-term use. Propranolol can aggravate variant angina because it is a non-selective beta blocker and it blocks beta 2 and beta 1 receptors. So, unopposed alpha mediated vasoconstriction will lead to vasospastic anginal attacks. That's why propranolol is contraindicated to use in variant angina. Beta blockers are the first line drug for prophylaxis of classical angina. It decreases the frequency and severity of attacks and it also increases the exercise tolerance. Beta blockers are also useful in the unstable angina. It decreases the sudden cardiac risk in the post-MI patients. Beta blockers are combined with the nitrates and amlodipine to counteract the tachycardia, which is often resulted by the nitrates. Calcium channel blockers, another class of drug, phenylalkylamine, that includes verapamil, benzodiazepine, which includes diltiazem, dihydropyridines, which includes nifedipine, amlodipine, clinidipine, banidipine, and nicardipine. Mechanism of action of calcium channel blockers. Calcium channel blockers blocks the voltage-gated calcium channel and decreases the entry of calcium inside the smooth muscle cells. So that will ultimately inhibits this pathway of myosin light chain kinase and myosin fails to interact with the actin, which ultimately brings about smooth muscle relaxation. Pharmacological actions of calcium channel blockers. Verapamil, diltiazem, and amlodipine are commonly used in the treatment of stable angina and vasospastic angina. Calcium channel blockers increases coronary blood flow and decreases the myocardial oxygen demand. These are secondary to decreased peripheral vascular resistance, decreased heart rate, and decreased contractility. Nifedipine causes fall in mean arterial pressure and that can cause sympathetic stimulation which results in reflex tachycardia and it can again aggravate angina. So nifedipine is shorter acting drug and it is not commonly used in the stable angina. Longer acting preparations like amlodipine are preferred in the treatment of stable angina. Calcium channel blockers causes coronary artery vasodilatation and relieves the spasm of the coronary vessels. That's why it has beneficial role in the treatment of vasospastic angina. Now coming to the adverse effects of calcium channel blockers. Hypotension, headache, facial flushing, and ankle edema. All these are due to excessive vasodilatation caused by calcium channel blockers. Aggravation of the myocardial ischemia is due to again excessive vasodilatation which is caused by nifedipine. Verapamil can cause constipation which is its most common side effect. Beta blocker, when it is combined with the verapamil, it can cause additive sinus depression and conduction defect. That's why these are not combined together. Patients with the sick sinus or AV node conduction defect should not be treated with the verapamil or diltiazem. Now coming to the potassium channel openers. Nicorandil, it acts by activating ATP sensitive potassium channels. It also causes release of nitric oxide and it causes vasodilatation along with that arteriolar dilatation. That's how it decreases the preload and afterload. It is useful in ischemic preconditioning, that is the brief episode of ischemia and reperfusion. Adverse effects of potassium channel openers are flushing, headache because it causes vasodilatation, and painful aqueous ulcer formation, which heals permanently once you discontinue Nicorandil. The use of Nicorandil is in the resistant angina when it is combined with the other first-line drugs. Now coming to the dipyridamole, which is a potent vasodilator. Dipyridamole inhibits the uptake and degradation of adenosine and it increases the coronary blood flow. Dipyridamole also causes coronary stale phenomenon. Dipyridamole causes dilatation in the non-ischemic zone, so it diverts the blood flow from the ischemic area. That's how it causes coronary stale phenomenon. Trimetazidine, this drug inhibits the mitochondrial long chain 3-ketoacyl-CoA thiolase in the fatty acid oxidation. Ischemic myocardium uses fatty acid as a substrate. Use of fatty acid is associated with the more ATP and ultimately more oxygen requirement. This drug will shift this metabolism to use glucose, which requires less ATP and ultimately less oxygen demand of the heart. These are also known as partial fatty acid oxidation pathway inhibitors. And these drugs are used as an add-on therapy for the treatment of stable angina. Ranolazine, this drug acts by inhibiting the late sodium current, which indirectly facilitates calcium entry through sodium-calcium exchanger. As it blocks the calcium entry, it will decrease the cardiac contractility, and that's how decreases the oxygen demand of the heart. It inhibits the fatty acid oxidation also, and it can cause postural hypotension and QT interval prolongation. So drugs which causes QT interval prolongation, they should not be combined with the ranolazine. Ranolazine is used in the treatment of angina as an add-on therapy. Ivabradine, it blocks the F channels in the SA node, funny cation channels, which opens during the early part of slow diastolic depolarization. Blockade of these channels will decrease the heart rate and ultimately that will decrease the oxygen demand of the heart. So the side effect of this drug is sinus bradycardia and visual disturbances. Ivabradine is also used as an add-on therapy for the treatment of angina. MCQ of today's class. Which of the following drug is most likely to aggravate prenatal angina? Comment in the box whatever answer is correct and let me know which topic you want to cover in the next video. Like, share and subscribe my channel to watch more pharmacology video. Thank you.